that you can look and assess the intraretinal fluid or IRF as well as the subretinal fluid or SRF. One can look for signs of chronicity on the OCT such as Outer Retinal Tubulations or ORT right here. You can look for drill or disorganization of the retinal inner layers. As you can see here, a homogenization of the retinal architecture and its loss. We can also look for signs of atrophy. As you can see here, this area is atrophic and degenerated. We can look at the component lesions which lie alongside the fluid component of the edema, namely hemorrhages and hard exudates, as you can see right here. Moving on, OCT is also very useful as a prognosticator and to help us assess response to therapy. As you can see here in this patient's case, at baseline with the acuity of 5/60 and a large amount of subretinal fluid and some amount of intraretinal fluid, this patient received the first dose of ranibizumab anti-VEGF injection. Vision improved slightly to 6/60 and you can notice a perceptible decrease in the subretinal fluid amount. And going forwards, after the third injection, you can see the acuity improved to 6/18. The foveal contour has improved, the edema intraretinal has reduced, and with the fifth injection, visual acuity improved to 6/9, and there is fairly remarkable restoration of the foveal and the macular contour. OCT also helps us detect surgical pathologies such as vitreomacular traction. You can see the traction here, the vitreous pulling up the macula, as well as epiretinal membranes. You can see this membrane right atop the retinal surface. So OCT gives us a way of classifying diabetic macular edema. There are 5 types. First, focal macular thickening. Number 2, diffuse non-cystoid macular thickening. 3, diffuse cystoid macular thickening. 4 has 4A, posterior hyaloid traction. 4B, epiretinal membranes, and 5, serous retinal detachments. DME can also have different morphological types based on the OCT. You can have a spongy edema, you can have a cystoid edema where you have these cystoid spaces abounding, and you can have cystoid edema with subretinal fluid. Next, we move on to OCT angiography, which is in a way the new kid on the block in macular imaging. It is a novel, non-invasive, dye-less technique of visualizing the retinal vasculature in the posterior pole. It's based on the principle where there is mapping of the movement of the red blood cells by analyzing the changes in the intensity and or phase signal that arises from repeated B scans performed in the same location. And you can see the architecture of the macula beautifully on OCT angiography. An example of an OCT angiogram of a patient with moderate non-proliferative diabetic retinopathy. In panel A, you see the octa of the superficial inner retina, which shows the presence of microaneurysms, as you can see here, scattered in the posterior pole and near the edges of the foveal avascular zone. Panel B shows us the deep inner retina and the presence of microaneurysms as well as some projection artifacts due to the presence of these hard exudates. Here's an example of an OCT angiogram of a patient with proliferative diabetic retinopathy. The octa of the superficial inner retina on panel A shows us extensive area of capillary non-perfusion and dropout. And in panel B, you can see the octa of the deep inner retina showing severe neovascularization of the disc and also macular ischemia. Moving next to the erstwhile fundus fluorescein angiography or FFA. Indications for this today are in the macula to look for macular ischemia to explain unexplained loss of vision, or to look for leaking microaneurysms where you might want to do focal laser. In the retina beyond the macula, one may want to look for neovascularization. Very importantly, it helps us differentiate from IRMA or intraretinal microvascular anomalies, and therefore differentiate from the proliferative stage of diabetic retinopathy and the severe non-proliferative stage of diabetic retinopathy. It also helps us evaluate the extent and the location of capillary non-perfusion areas. So if you find a sclerosed arteriole in the macula like this, you might want to order a fluorescein angiogram, and you would not be too surprised to find macular ischemia as extensive as this, alongside capillary non-perfusion, as you can see here. FFA can also pick out leaking microaneurysms like this, and the current standard of care is anti-VEGF treatment, but if it's refractory to that, you may want to add a little bit of focal laser to these leaking microaneurysms. FFA also helps us detect, importantly, neovascularization elsewhere in both the posterior pole as well as the periphery. So as you can see here on the fundus photo, the neovascularization is not very obvious. You have to look carefully to pick it out there. But on the fundus fluorescein angiogram, you see it's seen very clearly here, and you can also pick out neovascularization far out in the periphery. So it can also help you detect both neovascularization of the disc, NVD, as well as neovascularization elsewhere, as well as map out areas of capillary non-perfusion, as you can see here. So the fluorescein angiogram also helps us, importantly, detect intraretinal microvascular anomalies like this, and it's seen far better than on the clinical picture. Fluorescein, as I mentioned, helps us differentiate the neovascularization elsewhere from the IRMAs. It also helps us detect in rare atypical cases of macular neovascularization, as you see here in the late and the early frames. Ultra wide field fluorescein angiography has come in the last decade, and it helps us very easily detect diabetic retinopathy, proliferative diabetic retinopathy, which is isolated to the posterior pole or to the periphery, as you can see. Ultra wide field fluorescein angiography also helps us uncover peripheral neovascularization, which is hitherto unseen on our standard fluorescein angiographies. As you can see here, the neovascularization not picked up in the standard fluorescein angiography, but is easily picked up on the wide field fluorescein angiogram. Next, we move on to ultrasonography. Here's an image of an ultrasonogram of a total vitreous hemorrhage. As you can see, the opaque shadows right there. This is an example of a subhyaloid hemorrhage and an example of a vitreous hemorrhage alongside subhyaloid hemorrhage. Tractional detachments are also easily picked out on the ultrasonogram, as you can see an example here, and a focal tractional detachment here. Moving on to the other investigations which are not as commonly used as the ones I just described. Microperimetry allows us to look at macular sensitivity, and that is correlated to OCT macular thickness and visual acuity trends. Multifocal ERG or multifocal electroretinography again helps us look at the functional status of the macula, and this is also can be correlated to macular thickness and acuity. You can see here an abnormal multifocal ERG with an abnormal shape, decreased amplitude, delayed latency as compared to a normal multifocal ERG here. Multicolor imaging has also come into our armamentarium more recently. Here's an example at baseline where you find the serous retinal elevation and edematous retina showing up as a greenish component out here. And with continued anti-VEGF therapy, as the macular edema resolves, you can see that that greenish hue is being replaced by the reddish hue of the normal retina. And you also find the hard exudates, the succinate rings, the retinal striae seen here more beautifully and well delineated on the multicolor imaging. So moving on to our treatment goals, we have to treat the primary pathology, the offending pathology, diabetes mellitus, obviously first. Then we have to treat the other vision-threatening aspects of diabetic retinopathy, the macular edema, the retinal neovascularization, the hemorrhage. So our treatment options to do this are A. Institute medical therapy to take care of the diabetes. Intravitreal injections and implants are there. We have lasers and the surgical option, which is vitrectomy. Medical therapy, first step, we have to treat the primary underlying systemic conditions, which is diabetes mellitus. We have to treat any other secondary underlying systemic conditions like hypertension, hyperlipidemia, nephropathy, anemia. We have to investigate for all these very thoroughly with the help of our physician colleagues. Management of diabetic retinopathy, the two sight-threatening pathologies, diabetic macular edema and the proliferative tractional components. We have to take care of them. For DME, intravitreal anti-VEGF therapy injections are the first line of treatment. Intravitreal steroids may also be used. Lasers may be used also. In proliferative diabetic retinopathy, lasers are the mainstay. Panretinal photocoagulation, we'll see that in a bit.